Good afternoon, everyone. Thank you for joining us for day 3 of the AHI Leadership Summit. This is our 12th annual summit and our first ever virtual. My name is Courtney Shaler. I manage the Adirondack Rural Health Network for AHI. I'm proud to welcome you today on behalf of our CEO, Eric Burton, our board of directors, and the staff here at AHI. This afternoon's session, It's Not the Tech, It's the Touch, is presented by Dixie Como of Telehealth Associates and Dr. James Powell of Long Island Select Healthcare. We'd like to take a moment to thank our sponsors. This event's been going on 12 years, and without the partnerships of these organizations that you see here, we wouldn't have been able to raise it up and make it such a wonderful experience for our partners. So thank you all, and we look forward to being in Lake Placid, hopefully next year, where you can meet these partners and speak to them in person. Okay. Now I'm going to just go over a few tips to help you get the most out of your enjoyment today. Please confirm that you are muted and that your video is off upon entry. To avoid audio issues, please choose either computer audio or phone audio. Using both may result in an echo in the line for you. For optimal viewing, we recommend side-by-side mode. To activate side-by-side mode, click on the View options at the top center of your screen and choose side-by-side mode from the drop-down. We also suggest that you use speaker view. That way you can see the slides and the presenter at the same time. We encourage you to use the chat freely to submit any questions, technical issues, and any comments you'd like us to share with the presenters. If we don't have a chance to get to all the questions, we promise to connect you with our presenters after the event. And last but not least, all presentations will be archived on the AHI website by October 9th. This includes the slides and the recordings. I'm now going to turn my screen sharing over to James and Dixie.
Thank you so much.
You're welcome.
All right, I think we are live, and we'll take it away. So thank you, everybody. It's really exciting for us to be here, and we're happy and hoping we can share some information with you. I'm Jim Powell. I'm a board-certified internist and the Chief Executive Officer for Long Island Select Healthcare. LISH is a fairly qualified health center on Long Island. We serve about 7,000 adults and children. We provide primary care. We provide behavioral health service, dental, and specialty care. We have 8 offices throughout our county, and we have almost 130 employees at present. I'm also the medical director of 2 Long Island agencies that care for individuals with developmental and intellectual disabilities, or what we call IDD. I'm a former board member of the American Academy of Developmental Medicine and Dentistry, and also I'm on a review board for an OMH agency that helps underserved individuals as well. And I'm fortunate enough to be a voluntary staff member for the Stony Brook School of Medicine. And I have no financial disclosures to report. So if I had to summarize my experience, I'd probably say I've been focused on healthcare needs for those with complex patient populations, especially the IDD patients, for about 20 years. And in fact, about 40% of our patients make up that IDD patient population. My co-presenter is Dixie Como with Telehealth Associates, and I'll hand it over to Dixie. Dix?
Thank you. Thanks, Dr. Powell. So Telehealth Associates is a certified New York State and New York City woman-owned business. We've been doing this for about 15 years. And by this, I mean we have been helping all different kinds of medical and mental health organizations implement telehealth into their practices. We help people wherever they are in their journey, from just having initial thoughts about it to getting halfway through and figuring out they need some help. And so we have worked closely with Long Island Select Healthcare and Dr. Powell for a while now. The problems that we try to solve with our virtual care solutions are providing access to care, improving clinical outcomes, making teams more efficient, often all 3. And we have a sweet spot for federally qualified health centers and community centers, because we really enjoy working with the people who take care of the people who have the greatest needs, the most vulnerable populations. And that's exactly how we met Dr. Powell at LISH. We were involved in a grant back in a couple of years ago, and we invited Dr. Powell to be our supervising physician. The purpose of this grant for this New York State Department of Health was to provide innovative ways to provide urgent care to individuals with IDD. And we had about 2,000 people enrolled. And one of the things we did was provide telehealth through home nurses who went into the residences after hours and on weekends, and they carried a telemedicine bag. And so you see the telemedicine bag in this picture, and actually that's our nurse Layla, who was part of our program. And what she has done is she's brought the bag to the consumer, the individual who's in their home, and she sets up the telemedicine kit, and she opens it up and she connects with a provider like Dr. Powell, and she uses the instruments that are in that kit as he directs them to telepresent the individual back to Dr. Powell. And this was an enormous success, although it took a little while for the medical teams to, on both ends, both at the houses and inside of the clinics, to get used to it. But in the end, we were able to avert 86% of our visits, avert an ER visit, and we had a 99% satisfaction rate from both our patients and the clinical teams and the nurses, because once they understood what we were bringing to them, they were thrilled to have that extension of themselves. And one of the coolest parts about this is that as the patient, you're able to see the doctor on the screen, you're able to see yourself on the screen, and you are able to see what the camera that might be being used is showing the doctor. So if the nurse is using the otoscope to show Dr. Powell the inside of your ear, you're able to see the inside of your ear too. And it's a very big hit.
So what was interesting about this grant, it was that it was designed for individuals with IDD. So we had 2,000 patients enrolled. We had an urgent care program where we rolled out, and they connected to me. And this is all pre-pandemic. So one night in 2017, I was asked to see this nonverbal autistic individual who lived in a group home. He had 103 fever. He's jumping up and down, and they wanted to know what the diagnosis was and what could we do. And when I had the stethoscope remotely, and I'm listening to pneumonia on the other end, it just kind of blew my mind about what the capability of telemedicine and virtual care. And then even though we're an ER avoidance program, the other thing that was interesting is that there was a woman that we're following for asthma. She'd have flare-ups and we'd have to give her nebulizers. But what we discovered is that she would stop taking her inhaler 2 or 3 days before the visit, and she would do this on purpose. So we found that really what she needed was company, that she was lonely, that she needed someone to kind of come to her house and spend a few minutes with her and talk with her and have a laugh. So virtual care for me wasn't just about making a diagnosis, it was about making a connection and how to create an opportunity to really grow a relationship with the patients in ways that were never done before. After the grant was over in 2017, we said, oh my God, this is great, this is the future. And as you know, FQHCs were not able to get reimbursed for this type of service. So what we realized that we could do is we can kind of leverage an opportunity to use chronic care management for us and use the dollars developed through CCM to kind of help foster and grow a small virtual care program. In fact, what we realized is that if we can do this through our Medicare patients and we fund this, I had actually come up with the idea of actually using 4% of all our visits for 2020 pre-pandemic. We're going to be free just so we can get used to what is going to happen next. Unfortunately, COVID came, and as unfortunate as a public health crisis this was, it was also the catalyst for us to have this kind of wider telehealth adoption of medical care and understanding who benefits. And then the rationale for creating hybrid care models, really becomes stronger and stronger. Each day you're fully immersed in it. Now, we're all past Telehealth 101. We all know how to do the Zooms. We know how to do the visits. We know how to integrate into our services. But in my mind, a hybrid model of care, it doesn't mean that you have to utilize all the strategies that are available to you. But I think you need to create a list and a menu that you kind of check off the boxes and you look to circle the ones that you may explore in the future. So, perhaps now we have a texting strategy. We do chronic care management. We think about remote patient monitoring. And down the road, let's look at leveraging perhaps artificial intelligence and think of a long-term strategic plan. And I think having that hybrid model of care gets you ready for that, because a well-executed telehealth workforce can really speed the traditional process. It makes it more efficient. Lets us apply our resources to the highest tasks. And beyond that, it gives us an opportunity to deliver care in a more personal and more creative type of way. I think that the key of taking better care of people is to kind of increase the number and the value of what we call care touches to the individual. As you'll see, a touch can be delivered in a wide variety of ways. It doesn't have to be human. It could be a bot. It could be a phone call. It could be a text. But these touches create the framework that creates a true envelope of care that surrounds and really protects the patient.
We thought it would be useful to show you an image of this envelope of care, even though it looks really nothing like an envelope on paper. So I'm going to walk you through this model, and then the rest of our presentation will be exploring each of these and then explaining where we go from here. So at the center of this model are the 4 cornerstones of care: medical health, mental health, and maybe surprisingly, social health and even financial health. Those are the things that we really want to be foundationally looking at when it comes to individuals. And then surrounding that in the yellow ring are the modes of care. What are the types of care that are applied in any of these cornerstones? And so for many of the folks maybe on this conference, preventative and primary are what you're offering, but maybe there's also an opportunity to offer chronic care or episodic care or transitional, and certainly acute and urgent care. And then when it comes to how are you going to deliver that care, look at the blue ring. These are acts of communication for the most part, but it might be that you put somebody in a remote monitoring program. It might be that they come in for an office visit. Another care touch is a virtual visit done over video. An act of care coordination, making sure someone has their meds or making sure someone has their next appointment is another quality touch. Then there's the virtual diagnostic assessment. So if you think back to that photograph of Layla bringing the telemedicine cart into the home or to wherever the patient is, that's a care touch. A health screening is a quality care touch. So is a symptom survey being pushed to somebody on their tablet or in other ways online. Even a text or a phone call is, of course, a quality touch. And then, as Dr. Powell mentioned, using artificial intelligence to do activities that are repetitive, like even some kinds of triaging, certainly scheduling, helping people get onto their Zoom call. That is a quality touch as well. And so what we're suggesting is that the results or the outcomes of using these care modes in this way is that you get what's in the green ring. And so that you get improved medical and behavioral outcomes, and you get an enhancement in people's social and financial outcomes. You get greater satisfaction. You could reduce the total cost of care. You get the opportunity, and we'll talk more about this, to keep patients in the provider's ecosystem because you're providing more services. You have the opportunity to keep patients and care teams safer, especially in a pandemic. You are likely to get greater patient engagement because you're connecting with them more often. And then sort of the thing that everyone wants is greater patient adherence, so that they're more likely to keep their appointment. They're more likely not to run out of their meds. They're more likely to do the things they need to do to maintain their health. And just to put a little bit of a bow on this, the envelope of care model that we're describing here is in complete harmony and delivers the triple aim, but it also is a very good way to position a practice like LISH or a health center to become a provider and a participant in value-based care, because it's really about outcomes more than it's about transactions.
So to understand the focus on the touches, I think we'll spend a little bit of time talking about the components of wellness. And when we talk about those 4 categories of wellness, we decided to do this from an organizational standpoint, from an employee standpoint, and from a patient standpoint. So during the peak of the pandemic, we would have weekly COVID staff meetings, and we actually spent time discussing ways to improve, or if we could, even maintain some of the wellness of the organization, but just as importantly as the staff that we were supporting. So we talked about meditation. We talked about, do you tap into your 401k if there's issues with finances with you and your family members, and really make these things more apparent. And part of this mission was that if we can look at the wellness of the individuals that we serve and that we support through employment and even the organization, then it becomes part of the fabric of what we do. So someone could see a dentist, they can see a therapist, they can see the primary care doctor, and we can bring up conversations about social and financial wellness. And that allows us to kind of make it as part of the normal workflow of what we're doing. And when we look at what those four things are, physical is what we really know. That's, caring for the body, maintaining physical capabilities. Mental, we're also well aware of too. It's caring for the mind and practicing good mental hygiene. But, the social wellness is also extremely important. It's caring for our happiness, our friendships, our companionships, our intimacy and love, and the opportunity to have those interactions, which is so important. And then the financial wellness, so really looking at the social determinants of healthcare, looking at can someone pay their bills, where are they struggling, and they're having problems getting food, because all this really does tie together. And our philosophy is if we can improve one of these components of wellness, we can certainly help improve the other areas of wellness as well.
So we've talked about the cornerstones of care, and now let's talk a little bit more about the ways that you might increase your modes of care, and frankly, why would you want to do that? And the reason is you really do want to keep your patients in your ecosystem, and by offering things that they might go elsewhere to get yourself, you're able to do that. You're able to have a line of sight to them that is longer and broader. And able to provide the continuity of care, particularly during a pandemic when they might be afraid to seek care at all. Also, of course, it makes great economic sense for your practice. So you see primary care here on the screen. That's because, again, in Lish specifically, they were already providing primary and preventative care. Even pre-COVID, Lish was starting to use telehealth to provide urgent care. And it had set up a mechanism to provide a special email or a special link that they could use to get access to Lish physicians during off-business hours. And that was just starting to get a little bit of traction when COVID hit. Well, one of the things COVID did was keep everybody at home. So they weren't out of the home anymore. They were not going to program anymore. They were staying at home. And Lish discovered that they were able to switch to same-day appointments for urgent care as opposed to needing so much after-hours care because, frankly, everyone was home all day. So it's not post-COVID by any means, but enough time has gone by that people have become used to these same-day appointments. And now Lish is reopening and is bringing people back in, and you're seeing a hybrid model so that people can use same-day appointments for both urgent and non-urgent needs. And it's shifting the way people are thinking about when do I need to see a doctor and what is my expectation about seeing a doctor. There's another way, though, that Lish is providing both urgent and primary care, and that gets back to that mobile doc telemedicine kit. We're on the verge of launching a pilot where we will be putting a mobile doc in a group home that caters to pediatric patients, children. And so what we're going to be testing is, can we put a mobile doc in a group home so that, and then train the staff there. We can train a combination of the DSP staff, direct support staff, and perhaps the house nurse, whomever it makes sense to train, how to use the mobile doc to telepresent back to Lish's pediatricians and others in order to do urgent care visits and keep them from having to leave the house and to keep other people from having to come into the house during this time, but also to do wellness visits. And so you're able to create a visit by bringing the clinic to the home. And there's another way that they're thinking about using a mobile doc, and that is, Dr. Powell mentioned that they have 8 locations. Well, not all 8 locations are necessarily open right now, and there aren't the same doctors at all of those locations. So if somebody is out in, and if you're familiar with Long Island, way out on the East End in Riverhead, and they want to be seen by somebody who rarely has hours there, if you put a mobile doc unit in that Riverhead far out east office, and the provider is able to schedule appointments so somebody can go to the Riverhead office and be seen by that doctor who's remotely located but can see them using the mobile doc, that's another way to expand access to care, both primary and, if appropriate, urgent. So I want to talk about another thing, and that's hospital transitions. So Oftentimes, a patient or an individual will leave the emergency room, or I'm sorry, will leave the hospital and need to step down. They might need to step down back to the house, or they might need to step down to another facility. Well, Lish is now in a position using telehealth to be able to say, discharge them, will discharge them to our care with remote patient monitoring. And we'll use devices that are specific to their condition, and we'll do surveys that are pushed to them regarding their screenings and their symptoms. And we'll do video check-ins. And if we have to, we'll escalate it to a mobile doc or a mobile lab to take more tests if need be, and prevent that rehospitalization. Then there's episodic care, and COVID is a great example. So there are individuals who are presenting with COVID symptoms, getting COVID tests. They need to be quarantined in their home, and Lish can actually oversee them using a new technology. It's a wearable ring. It's easy to use. You put it on your finger, and it tracks data, and then waves of data, trends of data are sent to a clinical dashboard. Well, Lish can use that to monitor a COVID patient using the data for heart rate, pulse oximetry, and temperature. And then they can periodically send in the mobile lab to do another blood test or a swab. And then finally, there's chronic conditions. Now, Dr. Powell mentioned that they do CCM, which is Medicare's chronic care management program, and it's a care coordination program. So these monthly care coordinations are hugely valuable. It's one of the most valuable touches because it's a way of keeping a patient on track and able to be in compliance and adherence with their meds, their timing, understanding side effects, whatever the case may be. It's at least a monthly touch of a patient. Now, Dr. Powell explained that Lish is not reimbursed for remote patient monitoring as an FQHC, but they're doing it anyway, and he's going to explain why.
You know, so as we said, we're not reimbursed for remote patient monitoring. It's considered part of our global rate, but it's not going to stop us. You know, we've spent months upon months on demonstrations to find a technology and a workflow that help us in a valuable program. And in short, we're fortunate because we have the SCC award to actually purchase technology that we can really deploy right away. We had to really be careful of what we choose. We want technology that allow us to have a video visit, collect data through Bluetooth devices, and allow us to follow up on conditions. The thing about remote patient monitoring is that I don't consider it the traditional blood pressure cuff or glucometer. Excuse me. We want to look at it as a way to look at quality touches and create opportunity for us to gather information. You know, when you think about the traditional RPM model, it's about collecting blood pressure readings for 20 minutes, looking at that data, going through it, and making decisions. The technology now is becoming so far advanced, and these dashboards are becoming so good, you can get the information on 30 days worth of blood pressure readings in about 3 or 4 minutes. So what else can we look to? What else can we find? What else can we discover through the RPM platform to allow us to kind of expand upon really what we can do and how we can assist the patients? So for example, I have a patient who's being followed for hypertension. And what we found is that when you realized why there was hypertension, it was really because they were taking Excedrin every day for shoulder pain. And when you start to ask questions about, are you taking your medicines? Yes. Are you having any pain? Yes. And then you start to go location of pain and what's going on. And when you can tease out additional information through RPM, then that's really the power of the data. It's not just saying, we're going to follow the blood pressure, we're going to increase the blood pressure pill, we're going to do X, Y, and Z. It's about looking at that global picture of the patient. And the same thing about the timing of it. You know, we've discovered that sometimes our patients may have a little bit more depression or anxiety on the Fridays prior to weekend. It may be related to work-related issues or kid-related issues, so that if we can kind of look at what some of the triggers are, we can use the RPM data for us to kind of look at how we create more value in that experience. So quality touches, you know, what is a quality touch? So quality touches come from giving the patient what he or she values. It's an envelope of care created by continuous need-based flow of healthcare. It's information that they think is valuable, not a flood of information. We don't want to overload somebody with information. And a quality touch is important because it delivers something that the patient values. And we feel that you can develop a quality touch that can come from a text, a phone call, an email, the portal, the website, artificial intelligence, chronic care management, remote patient monitoring, video, as well as the time-honored in-person visit. And it could be as simple as a text message that reminds the patient to come to an appointment. A discussion with a dietitian about the healthy diet. It could be a prescription given for heartburn. We're trying to look at how do we objectively find the range of each person's needs across those cornerstones of wellness and care. And what are some of the observations that we've seen is that there's tremendous power with the provider being involved with the quality touch, but they cannot and should not be involved with all touches. There's just not enough time. Patient value is created with relationships, and intimacy can be built through the use of telehealth. You can see more personal space, you can feel more comfortable, you can actually connect them. What I realized is I was doing video visits in the beginning of the pandemic, and I was so excited to have my first live session. So I go running down the hall, I put my gown on, my gloves on, my mask on, my shield on. And by the time I was gowned up and I walked into the patient's room, I almost wanted to change my voice. Hello, this is Dr. Powell. How can I help you? Because I lost that intimacy of the relationship. Is that here we are in this brick and mortar structure thinking this is the ultimate in creating a relationship. But, in this pandemic of what we're dealing with, it really wasn't. And we both laughed, realizing that, we both look better on a video visit together. And this is what we have to pay attention to is where is the connection and how we best kind of maximize that.
So just to pull this together a little bit, the envelope of care is made up of a steady drumbeat of quality touches. And it's really a system generated by professionals who are looking at patient needs in a really comprehensive and coordinated way. And when it's done appropriately, it actually functions to nurture and protect and heal and manage and educate and engage patients. And doesn't that sound like what we all want to do? Now, in traditional medicine, more touches typically would require more resources and at a higher cost. But with telehealth technology, and we've talked about some of it, but there's more to come, you can deliver more touches more effectively, more efficiently, less expensively, and you can even achieve greater outcomes, and you can make it feel really, really personal. And a natural byproduct of that envelope of care is to keep patients in your ecosystem. So what Dr. Powell and I want to do now is talk about some of the new technology that's behind the touches, and it starts with the care team.
So we talk about some of the members on our care team. We decided to partner with an AI company called First Outcomes back in January. And the whole goal was to help us achieve our vision and create the workflow related to our envelope of care. So we're using artificial intelligence or automated care coordinators to communicate and do automatic repetitive tasks for us to kind of free up staff so they can work at their highest level. Ultimately, we feel like they can help us in a bunch of different capacities. Our first rollout with First Outcomes had to do with the pandemic. What they were able to do is create these chatbots for us to confirm appointments, make sure patients had connectivity, provide the Zoom ID for the visit, and allow us to not make phone calls for every visit that was done through the telemedicine platform. There was a large learning curve on all ends from the patient and the providers, and this allowed us to leverage and take away some of the mundane but necessary tasks that was there. So what was wonderful about this is that you realize is that if there's no friction related to this process, you get the text message, you confirm your appointment at 11 o'clock with Dr. Powell. Yes, you have Wi-Fi access. Any issues? No, this is your Zoom ID. Are you set? Well, that's great. But if there's any problems where the patients are struggling with connectivity, they can't get to the internet, they can't get the device to link, they decide to go to the store and they're out of their normal element, and they get really discouraged and they'll stop using the technology. So it's really up to the practice in the health center so that everyone in the entire chain of the care delivery model knows how to use the software, how to use the devices, how to deliver and receive the information, and also escalation becomes important. So it's great to have that initial information to go to the patient, but if you can't get it escalates to someone who's live and can help them walk through, you're losing that connection, losing that ability to really have them use this technology going forward. So we were fortunate. We leveraged Telehealth Associates to help develop connectivity assessments. We did RPM readiness assessments, so we can screen all our patients to see who'd be the most successful with the technology and how we can leverage the use of that technology. And we also realized we needed different learning approaches, based on what their competency was, so that some people are very IT savvy, some people don't have a clue. So it could be asking questions about, do you have a smartphone? Do you know how to take a picture? Do you have an email? How do you kind of create knowledge so it kind of helps us help the patients to really absorb the technology and take advantage of it? And then even when you think you have everything right, you've thought of everything, you realize things pop up all the time, that you have to be nimble through this whole process. That we realized that there were weekend staff in some of our group homes that were never trained because we did all our training Monday through Friday. So then we had to have our staff be available for weekend Zoom sessions and teach them how to use the website and email and whatever technology we wanted to employ with them. And yes, there's stumbling blocks, but this kind of helped us get ready for the next phases of where we're going to go. So after we set up the video visit bot, we decided to expand into some more care scheduling bots. And as you can see from the slide here, what we have is we use eClinicalWorks, and this technology is actually going into our patient data, looking at labs and looking at claims. And once we identify what programs and where the triggers are and where the gaps are, we're deploying the bots to help perform the tasks. Unfortunately, with our office, we have this probably 2.5 calls per patient visit. So our whole time stinks. The frustration getting to the call center for us is difficult. And when we leverage eClinicalWorks automation for telephone visits, what they would do is they would confirm or cancel a visit, but it would kind of stop and the loop wasn't closed. So if someone cancels the visit or wants to reschedule, our staff still have to follow that up with a phone call. So it really wasn't minimizing a lot of our time. But now, if the technology can allow us to say, okay, they want to cancel an appointment, but Dr. Powell has an opening at Friday at 10 a.m., do you want that? And book that now. Then we've reduced some of the mundane work that can be done and allow the staff that we have here to be utilized in other different ways. So when you take advantage of the bots, it's about thinking about how do you program to what your needs are. That every health center, every practice, has different needs, has different issues that arise. I think we all struggle with telephones, we all struggle with show rates, we all struggle with understanding technology. But if you can really address some of your friction points, you can really reduce your no-show rates. You can enhance your compliance. And you can really create the opportunity, even allow people to make sure they have the right transportation to go to the centers. So another type of technology that we're going to be rolling out soon is actually using nursing bots. And what this will do is actually review patient information, verify blood pressures. They can enter data before the visit, so they can maybe do our screening questionnaires. So it could be PQH9 scores, prepare scores for social determinants of healthcare, even vitals that they want to enter in there, so it helps load up our note. So, the hybrid bot integrates with the video app, such as Zoom for healthcare. So it not only helps the patient schedule the video visit, but connect them with them 15 minutes prior to the visit, as I discussed, just to make sure anything that they need is all set and ready. The last thing we want is the provider to spend the 15 minutes of their session on the phone with the patient, explaining how to use the video visit because they have to log on, click on, hit camera, mute. I mean, we have enough problems. I think all of us in this session have dealt with our own internal issues with Zooms and some of the technology with visits. But you can imagine how it can be expanded in the patient realm, which I'm sure you will appreciate. So hybrid practices, really have hybrid care teams. So a couple things to point out here when it comes to quality touch is that you have to think of the bots as part of our team. So when we've been working with our vendor, we said we want to make these scripts that it's not a bot, it's saying we, it's saying us, that they're part of the system. So we're having them say, we look forward to seeing you. So the bot is part of the we, it's part of the team, it's part of the group and part of that whole envelope of care. And second, we spent months on the training the bots in the language. If someone says, I feel lousy, what does that mean? How do we expand different questions to say, well, is it because you're depressed? Is it because you have pain? And then if we can't get answers, how do we escalate it to somebody so they can get back in touch with them? We started very conservatively with simple tasks. And the most important thing we have to say is that, AI does not replace you, that AI is going to help you. It's going to remove the mundane work that you do, and it's going to elevate your experience with the patient. Because what we're planning to do is not lay off staff. We're planning to reassign staff to say, okay, maybe you're part of the call center, you're part of the front desk. Now you're going to be part of more of the wellness team. So you're going to be part of this whole wellness move that we have, and really get more involved and have a bigger impact on where care is going. I talk about what I call the spaghetti strainer effect of healthcare, and how do we look at, team-based, workflows, and how do we think about the delivery of information and receiving it and retaining it. And, I spent 20 years seeing patients, and, traditional history, I would see them 4 times a year. And I really believed I was kicking some serious butt, like providing excellent care, giving advice, and being on top of it. And you realize as technology has evolved, like how wrong I was. And, I was taught in residency, you see one, you do one, you teach one. And this does not work in the real world. Even if you know what you're doing, there's always obstacles in the way of getting there. So if we can encourage others to help facilitate that information, so that I say, this is your advice for smoking cessation, and then someone else follows it up a few days later, whether it's through the text, or whether it's the bot, whether it's the care coordinator, that enhances not just the advice I've given, but reaffirms the learning that's required to get to the next piece and accomplish the goals that you're looking for. So, how do you quantify a quality touch? And the answer is, I don't really know yet. I think that there is a way that we're trying to figure out, how do we identify what the secret sauce is, how reliable it is, how reproducible our efforts are. And, then I start to think about, I have 4 children, and I try to teach the same life lessons to all my children. And as you can imagine, I had to do it 4 different ways for all these children. They don't make it easier for you, and patients don't always make it easier for you. So one of my, kids may need more reassurance. One of my kids needs more reminders and more examples of the way things should work. And one of my kids actually has to really think that it's their way, and I didn't teach them anything, that they did this on their own. And so that's the way we kind of work through trying to get the messages across. But in the same way, if I blast daily messages to patients about their blood pressure readings via text, they'll find another doctor. So we know that my advice 4 times a year isn't good enough. We know daily messaging isn't good enough. And some people need some sort of balance, and where that falls in the spectrum is going to be different for different people. So if you look at a real life scenario, you look at a text message that it goes to a patient to confirm an appointment, and then they come on site to the brick and mortar structure, they're evaluated by the provider, and they order a test for colon cancer screening. Let's say it's the Cologuard test. Patient leaves, a care coordinator or a bot ensures that the test is completed. They follow up with them. A message is sent to the patient to set up a follow-up visit. A video visit is then set up by the provider to explain this abnormal Cologuard test and the need for colonoscopy. Referrals completed, appointments scheduled, results of a colonoscopy obtained and reviewed by the provider. So preventing colon cancer is really a team-based workflow. It's not just the provider touching. There's at least 7, sometimes 8, 9, 10, or even more touches that are required, and each step is important. If there's friction in any of those steps, we're affecting our risks, we're affecting our outcomes, and we can't enhance them. And so that's why this becomes so important in terms of how do we deliver these messages and how seamless these messages can be.
So a burning question that you may be having is, okay, these quality touches sound great, but does everybody get the same one? As Dr. Powell explained, no. But then how do you decide? How do you decide who gets what? Which patients need what kinds of touches? Who's likely to be successful with technology? Who won't tolerate it? And these questions are not just clinical, they're also social and even financial. And so what this really needs is a model, we love models, a model for segmentation and stratification. And so Telehealth Associates built one back during the grant that we discussed earlier. And we did it again for this population, the intellectually and developmentally disabled population. And we realized that we needed to organize it around 3 things. First is their residents. And if you're not familiar, individuals with IDD tend to live in one of three types of residences. One is a group home that may have a lot of staff working there that are there 24/7 and that may have nursing support. Another would be living with family or a caregiver. So they have support, but it might not be clinical or medical. And then another might be living in an independent apartment, maybe with a roommate and maybe a little bit of oversight, but not daily support and not necessarily nursing oversight. And so where they live we realized had a lot to do with how many touches or how much care or support they might need. And then a second stratification layer is acuity. And that's taking a look at their spend in terms of how often have they gone to the hospital or the emergency room, and for what? What are their diagnoses? Are they high acuity? And let's take a look at their pharmacy. Are they polypharmacy? Are they using double-digit numbers of medicines? Because many do. And then finally, and this is something that we love to talk about, we actually used patient activation measurement system from, I just lost what it is, from Insignia Health. And Insignia Health has developed this proprietary system that's been around for a long time, and we've used it in a number of cases where you give someone a survey, either the individual patient or their caregiver, and they answer a series of questions, and this question is run against an algorithm, and the algorithm determines where they are in a quadrant, levels 1 through 4, in terms of their being engaged, understanding their conditions, feeling some sense of responsibility about their conditions, and being activated and taking care of themselves and seeking solutions for their wellness. And so level 1 is the lowest, and you can see here it says my doctor's in charge of my health. And level 4 is the highest level. It's a very high level of activation, and it says I'm my own health advocate. And you might be surprised if you took that survey where you might fall on here. But the value of PAM is it allows you to understand where somebody is and then be able to add a component, which is coaching for activation. And that coaching for activation allows a care team, if they are all trained in it, to be able to interact with that individual based on what their PAM level is and even what kind of condition they have. So there's PAM coaching by disease state, which is huge. So the value of those things is that it helps you understand, and you see here a template for a segmentation model, to determine the touch cadence and type. So if you see that down there on the bottom row to the right, where it's the darkest red, that's where the greatest need is, because those are individuals who are low activated, high acuity, and living without very much support. So you need to be identifying all different kinds of ways to touch and communicate with those patients in order to help them understand their disease state, stay on track, make sure they're doing the things that they need to do to stabilize and even improve their health. But if somebody is low acuity and they're highly activated and they live in a supervised setting, they need arguably the fewest touches, or the kinds of touches that don't require a lot of the most expensive kinds of touch or intervention. And all this is designed to help us deliver sort of the mantra of telehealth, which is the right care at the right time, in the right place, using the right resource to get the right outcome. But I have another mantra that I want to share with you, and that is take the path, find the path of least resistance. One of the things that we learned in our work and the initial grant and subsequently through working with Lish and everyone else is that if you can make the effort low complexity for the individual, you will have a higher rate of success. And so what does that look like? Well, first, assess and identify where are they on a level of competence, connectivity, and comfort with technology. And secondly, and Dr. Powell has mentioned this, use technology that the patient already owns or is familiar with. And bring the center to the patient if you can through mobile telemedicine, and create opportunities for care where people gather, and then recognize that low tech can be as powerful as high tech. So I want to quickly go through this last stuff here. Go ahead, Jim. So here's how we assess patients' digital skills. We assess whether they are comfortable if they have a smartphone or a tablet and they know how to use it. Do they know how to enter a PIN and put in a password? Do they know how to use an app? Are they afraid to use it, or are they afraid to learn? Are they so nervous that they can't learn? Do they have the connectivity in their home, either through Wi-Fi or cellular data? And then are they likely to be adherent? Are they likely to make and keep an appointment in an appropriate location so that they're not on the bus or in the grocery store or driving in their car at the time of their appointment? On to the next one. So here are some of the things that we do. We create solutions where they can bring their own device if they have one, use their own smartphone and a simple HIPAA-compliant app, provide instructions in writing, maybe create a video on how to log into the video visit, send a text through a bot 10 minutes prior to the link, with the link, and just say, just click this to enter. Then have the scheduler call to help them connect if for whatever reason they don't show up in a timely way. And recognize that these interventions can be done by a human or a bot.
So it sounds great in theory, but how effective are some of the initiatives that we've been able to do? So just to give you an idea of how we handled ourselves through the pandemic, we only had the furloughed staff that were deemed non-essential, so dental, audio, PT, etc. We kept all our nursing staff, all our front desk staff, and reallocated all our nursing staff and MAs and LPNs to chronic care management. So we went from 1,300 visits a month prior to the pandemic to almost hitting 2,000 a month. By mid-July, we were able to get back to our pre-pandemic numbers for the first time. In the last 2 weeks of September, we actually are 5% more visits per week than we were prior to the pandemic. And this does not include the added CCM visits we've been able to achieve every month, which leveled off about 1,800 now because we've had to change some staffing ratios as we pulled nursing staff back to the on-site presence. And one of the things we're most proud about is we have a 2% telephonic rate. So in the FQHC, we receive our full rate for on-site and video visits. So for over a month, we've had consistently 98% of all our visits that are our full PPS rate at 98% of our visits. And so just as we're getting toward the end here, just another way to look at the purpose, the outcomes of the quality touches is really it's about confidence, connection, control. And as you hear the story, you start learning more. It's about convenience. And then me personally, I remember going to a bank trying to transfer money, doing it online, can't get through, do the 1-800 number, had to go to the bank. It was a long process. So if you can't make it convenient, create confidence and create a connection with your patients, you're not going to create an opportunity for them to really want to be part of this for the long term for you. And just to summarize, so what are the tips of building a frictionless model is we start with pilots. We do small populations. We try to learn from them. We say we're going to make mistakes. We're going to fall down. We're going to improve. But we also are upfront with the staff and the patients about what our plans are. We tell our staff all the time, we are not the agency that's going to test out a new idea very slowly, make sure every variable is addressed, and then before we roll it out. We're nimble, we're innovative, and we're not afraid to lean into vulnerability. So really get ready to enjoy the ride. And then when you think about the workflow more than the technology. So, what we realized is that there were 3 buckets of staff members that we had. We had the oh yeah bucket of people who were excited, motivated, and all ready to go. We had the oh my God bucket where the staff had motivation and not a lot of skill. And then we had the oh crap bucket. And that's the staff that wanted to change but didn't because they had fear, they didn't have motivation, and they had to regardless. So we spent a lot of time with the oh crap people. Once we broke through this group, our telephonic numbers really dropped dramatically. And I think when you think about what you can do to minimize workflow and interruptions is think about what your patients like, what your patient enjoy. We decide to have our visits go on-site video, and fully mixed in with our patient experience, because that's what patients are used to. They want to have a 9 o'clock appointment, whether they're on-site or off-site. It caused more work and more chaos for our providers, to be perfectly honest. But we feel like it helped prepare us for where we were going in the future, when we really push the value-based types of stuff. And so, we don't want to disrupt the services. We want to kind of make sure our brand is part and throughout that. And you want flexibility and you want choices. You want to be able to provide the on-site and the virtual. Let them know that it's safe to be on-site. Also let them know they can get quality off-site. And we've expanded through our website. We've expanded through our portal. And it made us kind of even look at how we even sell ourselves, so that we actually decided to redo our website because it really didn't allow people to navigate that clearly. In fact, we even invested in some search engine optimization. And the initial discovery was that we found that 94% of the information that was on other sites about us had something wrong, a wrong phone number, a wrong address, the wrong providers. So now it's less than 5%. And in fact, if you search low-cost healthcare in Long Island, Lish is going to come right up to the top because we want to have a presence and prepare ourselves for the long term.
Well, we have come to the end of our presentation, and we appreciate your attention, and we appreciate the opportunity to share this this story and this journey that we're on with you. And we just want to know what questions you have, and we'd love to entertain them and talk offline as well.
Okay, so we have a couple questions. How long do you foresee offering remote patient monitoring with no reimbursement? And second part of that question, is Lish engaged in any sort of federal or state advocacy to get reimbursement?
So the RPM question in terms of reimbursement is, we've actually calculated that our RPM technology will generate probably 4 additional visits per year, or 1 per quarter, based on escalation of needs, so that there is still going to be value in visit generation for the RPM. So it's not a non-reimbursable, but it's not reimbursable through the RPM platform. And once we leverage that experience, we just think it's going to help us with our value-based payment contracts that we have, so that we're going to improve blood sugar readings, we're going to improve, depression screening. So we think there'll be secondary benefit through RPM technology. Advocacy, not enough advocacy. We'd love to be involved with more. We're trying to be involved. So I'd be happy to participate in any groups if anyone wants to offer any suggestions.
Okay. I may take you up on that, Dr. Powell. I'm actually on the advocacy policy committee for the New York State Rural Health Association. So we're always talking about telehealth. So I'll come back to you on that. We have another question. What kind of opposition, if any, has there been from patients receiving telehealth care? We have heard comments such as fear of the information being breached, fear of lower quality of care, etc. How do you navigate those concerns?
Well, it's actually, I think it's patient specific. Some patients have refused to go on the video format. And so what we had to do is, specifically for behavioral health, to say, okay, well, at what point do we stop telephonic visits and say you either have to come on site, come into the parking lot, and we'll give you a tablet so that you can talk to a provider, but create an opportunity that we didn't want to have long-term telephonic utilization, specifically in the behavioral health world, greater than 90 days. So we had given ourselves a mid-July timeframe to say, we either want you on site where there's no patients, that you're going to be in a room by yourself, or in a parking lot, we'll bring a tablet to you. So we want to create some sort of understanding of what they're. Once they were part of the system and we spent a lot of time training, we're really the 2% of telephonic visits for us is really more based on IT readiness, capabilities of the staff. So it wasn't, they really embraced it a lot more than I thought. In fact, some patients did a better job than some of my staff members.
Okay, here's another one. The flexibility is granted to the telehealth world since the public health emergency was enacted. Which one has been the most beneficial to your organization?
That's a good question.
Well, one of them might be that providers and patients can be anywhere.
Yeah. I think that we're almost looking at there's no rules right now, and I say this in the nice way. So I think we're still discovering how we find our new comfort zone of where things are going to go and how we pull staff on. I mean, I have some mental health providers that I'm not sure if they're ever going to come back to the office. They're working from home. It's working for us. They're safe. The patients are safe. But if they will have to come back on site and the patient can be remote, that may be an issue for us, and we may lose some providers. So we're really kind of exploring that still.
Okay. We don't have any other questions. Do you have parting thoughts you'd like to share with the group? Dixie's smiling. Would you like to go first, Dixie?
Well, I'm smiling because I actually got a private question, and so I'll just generalize it and respond. The question had to do with, as we survey people to understand their competencies, are we seeing some discrepancies in utilizing the tech for people with IDD, presumably versus people without IDD? I hope I'm interpreting that person's question accurately. And the interesting thing is, number one, we haven't got a huge volume of data yet. This is early days in doing this, but there are individuals who are independent enough to have their own phones and their own technology, and they are actually rather adept because they use these devices. There are individuals who are their caretakers or who are their staff in the group homes, and it's a pretty mixed bag, actually. In some of these agencies, they don't issue cell phones to the individual, to the employees who work in these homes. And so they're using their own cell phone. And so then they may or may not use a personal phone at home, and they may not have a lot of familiarity. So some of the work that we need to do when we bring a tablet or a remote patient monitoring kit into an agency home is really with the staff and helping them understand, this is how you log in, this is how you select this individual, and we could go on. But so it's a real mixed bag, and it's not only because some of the individuals have IDD.
Okay, thank you. Dr. Powell, did you have closing thoughts?
Yeah, what I would say is I think the last 6 weeks have given us a taste of what we think the new normal is, and no one knows how long this is going to last, but we're going to budget and project that the ratio of on-site and off-site care is going to probably maintain this ratio. So all dental is on-site, 85% of my behavioral health is off-site, 1/3 of my medical services is off-site. So we're going to look to keep those types of ratios in our understanding and then adjust accordingly, and just be mindful of that. It could get better, it can get worse, but as long as we keep knowing that telehealth and virtual care is going to be a component of all services, even dental in terms of screening and questioning and following up, then I think we're prepared as the pandemic lightens up or even gets worse.
Thank you so much, and thank you for your presentation. We really appreciate you spending time with us this afternoon.
Thank you. Thanks for
Oh, sorry, Dixie, go ahead. What was that?
No, I'm done.
Well, it's great to have you guys, and we hope you can join us in person when we move the summit back to Lake Placid. Thank you, everyone. Have a good evening.
Thank you so much. Have a good day, everybody.
Bye.